Welcome back to another episode of the Dissecting Medicine podcast. My name is Jesse. I am an applicant to medical school. In this podcast, I try to have conversations with different clinicians and researchers, people in public policy, to try and get a better understanding of the different disciplines within the health system and the health field, and also hopefully make me a more informed applicant, and to share these conversations with everyone else watching so that everyone else can share in this knowledge of the experts themselves. In this episode, this is episode number 6, I speak with Dr. Phil Jaksa, who is a consultant psychiatrist. They completed a Bachelor of Medical Science and then their medical degree both at the Australian National University in Canberra. They then went on to begin their registration. They, during their fellowship training, also completed a Masters of Psychiatry with the University of Melbourne, and have just recently completed their specialty training with the Royal Australian New Zealand College of Psychiatrists. So it was a really good conversation. We spoke last week for about an hour and a half or so, and we chatted about, obviously, the field of psychiatry, what led them to the field itself, what kind of inspired that interest. But we also got into some really specifics about things like the subtleties of psychiatric assessment and diagnostic process, the relationship between psychiatrist and patient. And we also talked about some of the difficulties and some of the ethical challenges that come up with managing some of these different health issues. So hopefully you enjoy it. I really enjoyed it and I took a lot out of it. I wish I had written notes while I was in there, but I was too engrossed in the conversation. But I usually try to afterwards summarize for myself some of the key things that I took from it. Hopefully you can do the same and take a lot from it. And hopefully you enjoy it. And I really appreciate you coming on and having a chat about psychiatry, because this was very highly requested as well. A lot of people.
Good to hear. That's great to hear. We're seeing that actually on the ground, but in recruitment. But I'll talk more about that if you're interested. I think it's great that you're thinking about this and sort of starting to plan. We can talk about the benefits of planning and the benefits of not planning and whatever you want to talk about.
That would actually be quite an interesting one, because sometimes I kind of go, is it almost a waste of time over planning when there's so many steps ahead? Because I kind of look at med school as like that's the training ground to really learn what you like and what you maybe don't like as much. Yeah.
We can talk about all of that. All of that. I've got my own views and my own approach that I'm happy to share.
Yeah, sure.
Like I said, I'm at your service. Whatever. I'll just happy to chat.
Cool. So I might actually dive in with one of the biggest ones. You might feel like you're going back to med school interview days, but just asking about what actually drew you to medicine initially.
Oh, that does take me back. I think initially it was two things. It was primarily just an inherent drive to care for other people, and interest in people that I had recognized in myself in my adolescence, in high school.
Right, okay.
And also a keenness for the sort of, and an interest in the science. It was the science actually to start with, and the care. So it was just a synthesis of those two things, that simply.
Yeah. And I guess it's something that develops over time. Because did you find at all that, like, is it still the same driving principles, or did that kind of evolve throughout med school and then through practice as well?
Yeah, these are great questions. Those are still very much underlying sort of driving principles for me. I think they're finessed somewhat now in that I've had time and experience to reflect on what care for others might mean. Right. And its relationship to self-care and care of systems and virtues that I think are important in medicine, like compassion and veracity and, perseverance and so on.
Yeah.
And I suppose my sort of the intellectual development of that, or rather the intellectual component of that drive is also broadened a bit. It's less so just about the science of medicine and more so now about the art of medicine, if you like.
Yeah. And is that kind of driven by, I kind of look forward in my own plans and kind of think it's really interesting, and that when you're interacting with patients, you are kind of towing the line between like just adapting on the fly to what you're experiencing, and everything is different. You kind of can't go in with a textbook definition of of everything because every person's different. Do you find that that's a big part of what's kind of, I guess, encouraging and exciting about the practice broadly as well? The idea that you're kind of on that line between what is fact or what is hard science versus what is the art of medicine, as you've said, kind of interacting with the patient.
Absolutely. And that's most relevant in the field of psychiatry, where empirically derived facts, if you like, are only as useful as they are applied to the individual person and family and system that you're responsible for providing care to.
Yeah.
So the interindividualness of medicine is I guess where you might say the art lies. And there are lots of different ways to think about that.
Yeah. And so with psychiatry as well, going back to the broader picture of like why medicine, we'll jump into the discipline or the specialization of psychiatry. Do you know when that was? Do you think you could pinpoint when it was that you made that decision, or is it something that's slowly developed over time?
I couldn't say that it was a singular point in time that I made the decision, but certainly there were points in the journey where I can identify an increasing interest that increased more so at those points in time.
Yeah.
I think I hadn't truly considered it until I did it as a rotation in med school, which was in my final year at ANU in Canberra.
Okay. Yeah.
And it was there that I had some meaningful patient interactions and was encouraged by a consultant that I began to consider it a bit more. There were things in med school as well around the sort of style of thinking that was applied to psychiatry that wasn't as applied more fully elsewhere, which was sort of the more ethical and subjective dimensions.
Right. And that kind of comes down to that subjectiveness of experience, like the fact that every patient's different. Psychiatry really brings that out.
Yes.
Yeah.
And, it's less about the sort of what's contained in the individual and individual's body. It's more about the context within which that individual exists or that person exists, the relationship to things within the context.
Right. Yeah.
I found infinitely interesting and more interesting than merely the sort of material reductionist biological sort of dimensions of medicine, which is there's ample of that in psychiatry too. So it just had so much to offer, intellectually and sort of emotionally and ethically, for my mission.
Yeah. And that's actually something that I was going to ask was because I thought about that, like in terms of the patient history, for example, in psychiatry. Do you find that's very different in the way that that's taken and the way, like, say, an initial consultation works compared to something in general medicine, like something a general physician might be doing?
Yeah, definitely.
That you're bringing kind of those social and relationship elements of who this patient is. That's
right. And not only that, I think you're also bringing in that relational element, the therapeutic relationship. So that is the relationship between the psychiatrist and the patient, right into your thinking right at the very beginning, such that the assessment process is not merely an assessment process, but also potentially therapeutic or potentially sort of healing in itself.
Right.
So it's not just an information gathering exercise. It is primarily, but it's also an opportunity for the patient to feel truly understood, heard, seen, which itself is the beginnings of healing, the beginnings of the establishment of a therapeutic relationship.
Right. And that's actually something like, obviously I'm preparing for interviews at the moment. And so looking a lot at and I guess the best way I could explain it is the kind of fragility of the relationship between doctor and patient, broadly speaking, how fragile that can be. Because obviously with the interviews, we're looking a lot at like, what is an ethical no-no versus what is good interaction. But I think in psychiatry, that probably puts greater pressure on the way that you handle that interaction. You said it starts from the beginning. in that it's almost like the treatment begins before the assessment is made, in a way.
Yep.
And I guess, like, especially with something like psychiatry and mental health, it's good that it's slowly being destigmatized and people are able to speak more openly about it. But I'd imagine it's such a nuanced kind of private issue for people that people might come into a consultation, especially if they've never accessed mental health services before, with some reservations. And that's probably really important. I would take it as a psychiatrist to be really mindful of those kind of things as well, to make sure you're keeping that communication open.
Absolutely. You're touching on context already. This is the cultural context, the zeitgeist, if you like, that we work within. The sort of, newly destigmatized or destigmatizing sort of cultural flavor at the moment, that people are emerging from a heavily sort of taboo area, and just making, tender steps into exploring elements of their suffering that were simply not permissible before. So that sort of understanding of that context is important on how you approach a person that's seeking help.
Yeah, absolutely. And did you find, you said that you kind of started to steer towards psychiatry after that rotation. Did you find that to be for you personally, I guess, did you find that easier in a sense, like it kind of molded with your strengths and what you're interested in? Or did you find that quite a challenging process to adjust to, compared to, say, like consultation and interaction in general medicine, adjusting to the differences in psychiatry?
No, for me, I wouldn't say it was difficult, and perhaps that was a part of why it felt more right to move into psychiatry. I think that intuitive sense of ease, like I wasn't trying to make myself fit something, fit into the culture of medicine, so to speak.
Yeah.
Rather, the culture of psychiatry fit what was already in me.
Yeah.
So when I did it as an intern, it really felt natural. I was given a lot of opportunities to work independently, had my own patients even on an older person's mental health inpatient unit.
All right. In the intern, yeah.
I just had a very supportive consultant who was extremely encouraging and willing to supervise me to do that. I presented at tribunal hearings as an intern, and it was just I think that's actually emblematic of the approach of psychiatry, which is that it's very person-centered. This person needs these things, and so I will adapt and accommodate to those needs to support them in service to them.
Yeah.
And so, I was fortunate to have that early experience in my internship, and that consultant supported my application to the college. And in my first resident year, I ended up offered a position as a registrar, which is just very fortunate that I had those experiences. Very fortunate.
Absolutely. And that was actually something I wanted to ask, because some people might be watching and considering psychiatry specifically and might be a bit confused about the training pathway. So could you explain, kind of list out the steps, I guess, from once someone graduates from medical school, what's the general process? Obviously, it varies with the number of years it might take for someone to go into the specialty program. But what are the steps that someone might be able to take to move towards specialization? Okay.
So I guess it needn't start in med school, but it can. And I would just begin by encouraging people not to feel too pressured to choose a specialty early on, or to start making inroads into a college early on, because you will experience a lot of that in med school, which I think it's useful if you're already very clear on what you want. And at the same time, it can be narrowing prematurely, and you may miss things that are otherwise opportunities for yourself that you might find that are meaningful to you individually. And it may also mean you miss out on other sort of knowledge and wisdom from other fields of medicine that you can apply to your chosen specialty. So that's the first thing that I'll say: stay open. And that was my approach. So in medical school, some things that you can do if you already know that you wanted to go into psychiatry is to use your research project as an opportunity to do some research in the field of psychiatry. If it's honors level research or sort of publishable research, especially in a psychiatry journal, you may be able to use it in recognition of prior learning in your training through
Yep.
the College of Psychiatrists.
Yep.
And the other thing you could consider is starting a formal education, one of the formal education programs before actually starting on the accredited training program. So that would be like a Master of Psychiatry through Uni of Sydney or Uni Melbourne, Monash University. It depends on the state that you're training in.
I see. And how does that work? Because I saw that you'd completed a Master of Psychiatry at Melbourne, for example, and I was really interested in that because it was, I can't quite remember the years. Was that before fellowship training for you, or was that during or after? During. Okay. And so how does that factor in to the process? People can do it either before or after or during. Is that right?
Before or during, and it depends on the state. So maybe the best thing that what I ought to do is describe the training program broadly, and then we can sort of just so that your listeners, your viewers can understand, just orient themselves.
Yeah, no, that's good. Yeah.
So it's a 5-year full-time training program.
Yeah.
And it comprises 3 stages.
Mm-hmm.
Stage 1 is basic training, where you do 2 6-month full-time equivalent rotations in acute adult settings.
Right.
So that is inpatient adult psychiatry, and usually an outpatient or community-based adult rotation. That's continuing community treatment teams or mobile support treatment teams, those kinds of things. Sometimes they're in sort of psychiatric assessment and planning units, those kinds of things.
Yep.
Stage 2 is for 2 years, full-time. And there you have to do 2 mandatory rotations that are 6 months in duration.
Mm-hmm.
One is child and adolescent psychiatry. The other is consultation liaison psychiatry, which is my subspecialty. And then you get to electives. And there are quite a few things that you can choose from, but it depends on the service within which you're training.
Right. Yeah.
So what you might be offered or what you might seek really depends on where you're training.
Yeah.
So it could be everything from homeless outreach psychiatry to addiction psychiatry to old age psychiatry, inpatient or community. It could be in forensic psychiatry, in courts or in prison settings or in forensic hospital settings.
Yep.
And a myriad of different things.
Mm-hmm.
And then in stage 3 training, this is your advanced training or potentially subspecialty training. And there are a whole bunch of different subspecialty or advanced certificates that the College of Psychiatry offers. There's consultation liaison psychiatry, addiction psychiatry, forensic psychiatry, child and adolescent psychiatry, psychiatry of old age, and psychotherapy. I think those are the 6. And so then you do 2 years full-time, at least, in rotations relevant to that field.
That one subspecialty. Yeah. Wow. It shows how much.
An adult, I should say. There's an adult.
An adult psychiatry. Yeah.
And then there's generalist, where you don't have to differentiate. But I think the college is moving towards encouraging people to do advanced certificates.
Right. I guess that would make sense given the investment of 5 years of training, that you would have a specialization at the end of it as well, like a subspecialty. Yeah. It's interesting because is that something, I'm not sure if you'd know, but compared to other training pathways, psychiatry is all in the one, isn't it? So it's a 5-year program, start to finish.
Yeah.
And then, because I've looked into some of the other pathways, like for me personally, I'm quite interested in pediatrics. That's something that I'm kind of loosely kind of eyeing off as something that I'd like to pursue, but keeping my options open. But a lot of the subspecialties in, say, that field happen in it looks like a separate 3-year program. It's like 3 and 3 or something like that.
Okay.
So it's interesting the way psychiatry works. It's almost like obviously it's a much higher qualification, but interesting that you can have a specialization within it. So everyone's going through that same generalized training, and then people fork out into the thing that they're really most interested in, I guess.
Yeah. And you can do dual training, or you can do the advanced certificate training at any time. You can do it as a fellow, once you've finished. There's lots of that. You can pace yourself as well. The last time I looked, only 16% of Victorian trainees finished the training program in 5 years.
Yeah.
So it's sort of normal if you like to kind of pace yourself a bit and explore your interests whilst in the training program, and even take breaks in training and explore your interests as a locum or in other settings. There's a lot of that.
That's really good to hear, because that's not something that I've ever really, I guess that's not the sentiment that I was getting, but obviously I'm a bit naive to the process. But it almost feels like I've been a little bit intimidated by the idea of specialty colleges broadly, just because it feels quite pressure filled. I don't know if that was the experience you had as a med student or as a younger applicant, but it's good to hear that there's that flexibility to stop, put a pause on things, pursue another role, for example, and come back to it, or that it's
the College of Psychiatry is in some ways flexible, in other ways quite not flexible. But I, from a training point of view, but certainly, I've seen plenty of trainees take breaks in training for a variety of reasons, and the college is generally quite accommodating to those things, whether it's to have children or to do some research or just to stop doing an accredited training position so that you can get through some of the summative assessments, which I haven't yet talked about.
Yeah, I was going to ask about how some of the assessments work. I think a lot of people watching are really interested to know a bit more about how the actual specialization, like specialty training program, actually operates.
Yep.
How does it work?
So there are two broad assessment sort of approaches in the College of Psychiatry.
Yep.
Those are competency-based assessments, which are workplace-based, and provided by and sort of conducted by your supervisor, direct supervisor. And so there's that. And then there's the sort of centrally administered summative assessments, so exams and submissions.
Right.
The competency-based assessments are a bit like an apprenticeship model in that you see how your consultant works and you learn through modeling, and you learn through bedside teaching, you learn through reinforcing some of what you've observed with reading.
Yeah.
With a formal education program, through journal clubs and so on. And then you discuss cases with your supervisor. They observe you conducting interviews and having therapeutic interactions with patients and families. And then they have a framework for providing feedback so that you can develop in that model. And these are workplace-based assessments. And there are certain competencies that you need to demonstrate that you're sort of proficient at fulfilling. And your supervisor, accredited by the college, will determine that with you. So these are these certifications of entrustment, this entrustable professional activities, they call them.
Right.
You're entrusted to do this particular activity. So it might be antipsychotic prescribing, or it might be psychoeducation, or that kind of thing. Yeah. And then every 6 months you have what's called an in-training assessment form, which is like a report. You do it at the middle to flag any areas of development that are required, and then at the end, and that's how you pass rotations.
So that's kind of like a performance review almost.
Yep, exactly that.
Yeah, I see.
But it's not for your employment per se, it's for your training. Yeah,
it's still separated in that way,
Yeah, of course they're linked. If you're not performing as a trainee, you may not be performing as an employee, but and vice versa. But yeah, it's separated. Yeah,
I see. I've always found that quite interesting, that the way that the training program works, that you're in training, but you're also on the job. Not to derail the conversation too much down that path or anything, but is that at all like challenging or confusing at times, or to be in both a role of responsibility, but you also know that you've got someone like your consultant above you that's kind of, I guess, that you're under assessment a lot of the time.
Yeah, you're very perceptive, Jesse. There is a constant tension between meeting your training needs and meeting the needs of the service.
Right.
They're not always confluent. So, one example might be, as a registrar, at least in Victoria, you're supposed, no, this is actually a training requirement. You're supposed to have a number of hours, half a day per week, full-time equivalent, to have your own academic time, away from patients, away from the work. And yet there may be service requirements, like service demands, that might compel you, or at least make you feel that you need to remain in the workplace and forego that training time.
Right.
To do work.
Yeah.
patient-facing work. That's just sort of one tension that you see, and that trainees often experience, and there are many others. As the hospital coordinator of training, I have a sort of a duality of interests too. I'm involved in recruitment and retention of trainees, and also helping them navigate the training program and supporting their professional development. I have to sort of work with trainees who have those interests, training interests and training needs, and also services who have service needs that interplay with those. Yeah.
Right. So at the moment, I was going to ask about your role now at Mildura Base Hospital. So you're kind of the intermediary between trainees and the hospital, effectively, in a way.
I mean, look, it's a small service here, so it's quite different to how it operates in cities where I'm from.
Yeah.
But yeah, it's that the role itself, which is very new to me, Jesse. So take what I say with a grain of salt. It is one of negotiating, I guess, the tension between those two competing sometimes interests.
Yeah.
It's important to say that a lot of learning occurs through the work, but there also needs to be support to learn away from the work, to back up, I guess, what you witness experientially with what you can learn academically and intellectually.
Right. Yeah, I guess, it's just about managing those competing interests, because I'd imagine like COVID, for example, especially with something like psychiatry, did you find that COVID put greater pressure on that relationship because there would have been a much greater need for the services during those 2 years?
That was very setting dependent, actually, I have to say. So where I worked during COVID was not a place where I had those demands placed on me.
Okay.
I was in an outpatient perinatal, private perinatal clinic, providing parent-infant psychotherapy and assessment and sort of mother and parent-focused psychotherapy and treatment. And it was all through telehealth, so my demand didn't change.
Yeah.
And we actually saw a decrease in demand for inpatient services because people stayed away from hospitals.
Right, that's true.
But crisis services saw a major increase in the workload, and emergency services, in particular in metro settings. So it was really setting dependent. Yeah.
Yeah, that's really interesting. Yeah, I'd imagine a lot of, I don't really want to make generalizations about subpopulations, I guess, but you've said crisis situations or crisis services, especially with looking at things. I know there were statistics that were really worrying about like domestic abuse and things like that going up during lockdowns and that kind of thing. I'd imagine those kind of services as well would have been put under a great amount of strain. And that's quite a difficult one to manage via telehealth, I'd imagine.
Yes. So those weren't, those were face-to-face with PPE things, and that changes the whole interaction. So much about how we communicate non-verbally is here.
Yeah.
And, it really, I have to say was and has been and is a challenge currently. But remember also that mental health services aren't the only services that operate in the crisis context. So there's social services, housing, domestic violence, family violence services, sexual assault type services, forensic services that also operate in this environment. Yeah. And so it's a collaborative process across agencies and across teams. So it wasn't just.
And that was something I wanted to ask as well, about how much kind of consultation you do with other support services, or I'm not sure whether, I guess it's more community and social services that you'd be interacting with broadly. Do you find is that quite a common thing to be working in collaboration with other teams when managing patients?
Very. The degree to which you collaborate varies, probably between settings and depending on the other teams. Certainly, there's a lot of collaboration within a team, and I would consider psychiatry to be a bit more horizontal in its organisation than vertical, less hierarchical. Okay. So the registrar performs some functions in the team, but they're not the person necessarily that is the custodian of all knowledge. Same with the consultant. We just have different perspectives, and social workers, nurses, occupational therapists, psychologists, and with those diversity of perspectives, we can provide a better outcome, hopefully, and understanding for our patients, carers, families, community.
Yep.
So working collaboratively requires a lot of listening, humility, negotiation, compromise. It's a very relational field in every way, not just with our patients. But
it's so different, isn't it? And I guess that goes back to that's demonstrated by I'm not sure if they're a registrar or consultant that was supervising you during your intern year, going, yep, I'm going to give you patients and I want you to kind of take the reins and learn that way. That's that culture coming through very, very early on.
Yes, absolutely. And I think this is something that medical students and juniors experience almost universally when they come to psychiatry, is that they find it culturally quite distinct compared to the rest of medicine and surgery.
Mm-hmm.
That they find themselves. Look, I am generalizing, but from what I've heard in a diversity of settings in a diversity of states now, they often find that their experiences are acknowledged and given regard to, and the psychiatrist will take an interest and say, what you're interested in, and I certainly do. I love to hear about what students are interested in and supporting them in their journey, whatever it is. It doesn't have to be psychiatry, and that's what we're about. The subject, if you like, the person's inner world and experiences and values and mission, as opposed to the objects, which is very sort of the medical side of things. To be objective is to focus on the facts, what's materially sort of true, and I don't want to sort of plunge your listeners into some intellectual pursuit, but the sort of philosophy of psychiatry is different in that way.
Yeah, that's really interesting, and it's something that, it makes total sense, because it would go against the principles of psychiatry, like broadly speaking, if those that were practicing it then held a really strict, hard and fast rule about the way they operated. Obviously, there's policies and guidelines and procedures to follow, but interesting that you said, there's that flat hierarchical structure. Everyone is listened to. Every opinion is valid, so to speak. It makes sense, because that's exactly the approach you have to have as a practitioner with patients. That you can't be going in with preconceptions or anything.
And in team. Now, look, it doesn't always work like that. Obviously teams are complex and human systems are complex, and there is the holding role of the consultant. That there's a lot of tension and anxiety sometimes in managing people that are very risky, or that might have behaviors that can cause harm to themselves or others. So, understandably, teams get a bit sort of worried about what might happen and their responsibility for that. And so, there is still leadership in every part of a team, and sort of the consultant and registrar play a role in containing those fears and anxieties in a team through sort of how they comport themselves within the team, but also how they use their knowledge, wisdom, and emotional intelligence to support the whole system, which includes the team and the patient and the family. Difficult to describe in words.
It's probably, I was just thinking about something that I was really interested in as well, was about how you go about, say, interacting with a patient where I don't know whether or not this is maybe false, but do you ever come across patients where you can tell they're not being fully forthcoming with information? Or do you find that, I guess the balance between having to discern how truthful the information is or how full that information is versus not going in with preconceptions or assumptions about them, is that a difficult line to walk as well?
Yeah. Is it difficult? The degree of difficulty probably changes with your experience, but trying to think about how best to answer this. One way to answer it perhaps is to consider the importance of trust in a therapeutic relationship as a foundation for the quality of the information that you might get in a psychiatric interview. And trust is sort of proportional, if you like, to the level of engagement that you have with your patient.
Mhm.
I use the word patient deliberately, by the way, Jesse. Others don't in my field, because patient comes from a Latin term, patiens, which means suffering. And to my mind, using patient inherently acknowledges that the person coming to us is experiencing a form of suffering, and to hold that compassionately is really important, because to do that, it places them, it gives their sort of experience primacy and their needs primacy over your own needs, which may be really hidden from yourself. Like the need to be right, or the need to know, or the need to have power. So that those things can really affect your judgment, and your understanding, therefore, of the patient in front of you and the situation. So there's a tension, I guess, in the psychiatric assessment process between engaging a person who may not be forthcoming for various reasons, probably due to trust or other things, stigma and so on, engaging them, the tension between that and the need to gather information.
Right.
You can spend all the time just focusing on closed questions and getting lots of information, but the quality of that information is determined by how engaged the person is. And so there's this kind of tension arc between the two. You can fully engage someone and have a lovely conversation, a very befriending conversation, and really not get much information at all about the person and their situation.
Yeah.
And so in psychiatry, it's this synthesis of these two things that you need to really be flexible depending on what the patient needs at that time.
Right.
And so you might find in child and adolescent psychiatry, for instance, with adolescents, you might need to do more engaging early on before you can start to get a bit more information. And to do that, you might have an adolescent who's just tried to kill themselves in a really serious way. And that requires a lot of self-reflective kind of holding of your own anxiety and your own sort of urging to get information, because you need to know how to protect them and support them.
Right.
But to do that, you need to engage them. So, it's a complex process. And to navigate this, trainees get an hour of supervision, one-on-one, every week. It's mandated by the training program. And it's a space where you do the competency-based assessments, you discuss cases and the supervisor gives you feedback and you do all the formal stuff for the college. But it's also a space to reflect on yourself and your experiences with patients, and how you found yourself feeling in relation to a particular situation, and sort of sifting through the biases and what you bring to that encounter.
It's really interesting, and it'd be such a dynamic process too, because I mean, you could be seeing a patient over the course of months, for example, and you're still working on that. It's effectively, it's rapport building, really, isn't it? And it's just constant rapport building.
Yeah, rapport building.
But it's not the same as a casual sense, is it? Because as you said, like ultimately you've still got to be able to draw that relevant information, because that's important to actually either protecting them if it's crisis, or at least managing their health in that time. And so it's one thing to get that engagement, but if you don't have the information that you do need, you're not able to do much with it.
Indeed. And sometimes a lot of our information comes from families and carers. So collaborating with families and carers and sort of holding their fears and concerns, it's all a part of the assessment process. Oftentimes, in fact, I would say it's uncommon to have the patient as the only source of information, in public, at least, public psychiatry. And it's important to have an alliance with not just your patient, but also your patient's families and carers and others, support people, because everyone's involved in supporting a person, a community of people, if you like.
Yeah. And how does that work with? My mind can't get off interview ethics and things, talking a lot about autonomy of the patient, but
please, I love this stuff.
And the kind of I'd imagine ethics in psychiatry is huge. It's thinking about that, like you said, the whole families involved. What happens if, say, I know this is a real hypothetical, but if the patient doesn't want their family involved, and you've got to obviously respect their confidentiality, does that just limit the sources of information and the kind of relationships that you can work with? Or
This is a very complex area, and I'm quite pleased that you've identified it already. It depends very much on risk, risk to self, risk to others, and certainly as a practitioner, you can be justified in obtaining information from other sources despite people's preference for that not to occur. But information sharing is a sort of a different thing altogether. So you can still maintain a degree of confidentiality, quite a high degree of confidentiality for patients by not sharing information, but by gathering information.
I see. Yeah.
Which is ultimately in service to the patient's suffering anyway. Yeah. And suffering, you need to think of quite broadly in psychiatry, because there's suffering of the individual, of the patient. There's also suffering in the family system and in the community social system. And there's suffering, sort of the more obvious forms of suffering, like emotional tumult and pain, but also the kind of suffering, at least that we believe in our culture, about the loss of autonomy through illnesses such as psychosis, where you might believe, due to an illness, that you're being persecuted by a system of agents that are harming you with lasers into your brain, and you need to defend yourself against these people, and just people in the community.
Yeah.
And you're acting upon these delusional beliefs. Your autonomy, your loss of your autonomy, your loss to sort of legislate moral action, your own sort of, is totally eroded by that illness. And so you may really not want anyone to treat you because you think they're part of the system that's persecuting you. That guy, that psychiatrist, he says he's a psychiatrist, but he's trying to kill me with these medicines, these drugs, you call them medicine.
Yeah.
So, that's why we have legislation to kind of protect people, patients, from illnesses like psychosis, and preserve their, ultimately sort of restore their autonomy, if you like, through treatment of psychosis.
Yeah.
It's a complicated area. It's difficult to know how to answer.
Yeah, I know, that's fine. It's probably one of those things that is very much case by case. You'd have to take into consideration each of the elements.
Very case by case, case by case. So, there's no sort of
hard and fast rule.
Can't do
that. Yeah. Interesting.
Yeah. I think that's one of the reasons that I was drawn to psychiatry too. It's not it's not a black and white field. It's not, I don't know. I don't want to look at another example in medicine because I'll reveal my ignorance. I was going to say, like a fractured neck of Fina, there's a finite number of definite approaches that you can take to that as an orthopedic surgeon, I would imagine. And it's not so grey. There would be grey areas, I'm sure. It may not be resolved what the best way to do. And there may be different types of broken neck of femur that I don't know about. But there's a lot of grey in our field and how you approach a specific situation. There are guidelines, there's empirical evidence, but you need to synthesize the objective dimensions of psychiatry with the subjective dimensions of that particular situation and subject.
That'd just be, I can see that would just be really intriguing in that nothing's ever the same. So just going back to the fact that I think there is an intellectual component to medicine that I think is appealing to a lot of people who pursue it. And I think that for me, it's such a challenging thing. Like, I look at it as, I try not to, I guess, like, romanticize medicine in my own mind. And I do try to think of it very practically and about the fact that ultimately this is a career choice in the same way that I could choose another career. And I'm kind of like, I'm switching at the moment. Like, at the moment, I am a private tutor. I've done that for 12 years and I've run a business doing that. And then now I'm making the switch and I'm like thinking about, how does it appeal to me? Why is this the right decision? And I think part of it is that there's got to be some kind of personal satisfaction that comes from it. And I can see why as well, apart from obviously the broader picture of helping people, caring for people, is that there would be a real motivation that comes from knowing that no two patients are the same. I mean, you could say the same thing about general medicine as well, but I think with psychiatry, it adds in that element of like dynamics to it that every patient is different, every case is different, and even every day with that patient can be different as well.
Yeah.
And that
Yeah.
idea of having to adapt to it would be just a very rewarding challenge to work through.
Absolutely, it really is. It really is. And I think it's just, for me personally, it was the field that I think would cater to my sort of inherent curiosity for a whole career, you know, a decades-long career. You know, you can become quite technically brilliant in procedural medicine and surgery if you want to, and that may be just awesome for people that are really into that, you know. But for me, you know, the sort of having enough complexity to satisfy my curiosity and sort of, you know, was important in my decision. I think you're touching a little bit on vocation, by the way, when you talked about, and you did cut out for a while there. Something happened on my end, so I missed a chunk. It's not you, it's on my end. So I missed a chunk, but the kind of, yes, it's a job, and yes, in this sort of economic system, we need to earn an income to support us. And we may have interests outside of our job, and it's important to have them, and family and a life and, you know, mortgages. At the same time, you know, medicine can, and the specific fields can become or are vocational to some people, or a confluence between their skills and abilities and interests, and their sort of personal missions, virtues, ethics, and philosophies to life that make it a whole lot more enriching, or can make it a whole lot more enriching. And certainly, I think I've been fortunate to find that in psychiatry, and hopefully others will find good fortune to find their vocation in their careers too. But it's not the only way to find vocation. I think we're told that.
Oh yeah, absolutely. And I think it comes down to that thing of, like, for me, I look at if the vocational element of it is satisfying my, say, vocational needs, if we make up a term for it, then I know that I'll be long-term, there'll be no limitations to my motivation to pursue the mission that I'm on to do what it is that I want to do with medicine, for example. In the same way that, like, for me, truthfully, I'm looking at switching out of what I'm doing right now, not because I don't enjoy it or because I've lost interest in it. It's almost like a parallel jump. And so I've kind of, going into this, pursuing this now, I'm looking at, why have I stuck with my existing career for so long, and what is it that I really enjoy? And I think it was that the merging of both vocational needs with something that I see as really, really valuable, something that I'm able to do with my life. I can walk away from at the end of it and say, I'm happy that I did that, and I'm glad that I contributed something positive. And I think for people to be able to, not that everyone has to go in with a clear idea of what they want to do, but I think that long term, if there wasn't some personal satisfaction for me as well, then I would be in some ways like a martyr, in a sense of trying to be the true altruist and then lose the passion over time, or it could lead to poor practice or something like that. So I kind of think I need to be making sure that I'm satisfied with the role that I'm pursuing at the same time.
Absolutely. You know, careers are long, and you know, the context that we practice medicine within has its challenges. You know, there are resource constraints, and we have goodwill. The vast majority of us have goodwill to practice, you know, really wanting the best for your patients in a system that has constrained resourcing can be fertile ground for moral injury. It can be painful to bear witness to the suffering of others and feel that you can't do enough. And so, you know, it's important to, I guess, go into this work with your eyes open to that, and also with your eyes open to your own needs, that also need to come from outside of your career, outside of your work. There is a tendency, I think, amongst doctors to be self-sacrificing. I think that's just a bit of part. That's just a bit of our culture, I guess. But also, you know, and I refer, you know, to sort of Christian dogma, or even you know, the sort of prevailing sort of philosophies in our system about, you know, the different mythologies of carers. there is a close relationship, I think, between the care of others and the care of self.
Yeah. It's really interesting.
Yeah.
And so I'll switch over because I wanted to make sure we spoke a little bit about some of the research that you've been involved in. There's not much of a segue here, but I noticed I couldn't find the original paper, and I really, hopefully I'll be able to get my hands on it so I can read it, but the one about psilocybin-assisted psychotherapy.
Oh, I see. Yes, no, that's not published.
And it's not published. Okay, that makes sense. I wanted to ask just a little bit about that research and like what the relationship was, but I guess first it was looking at the treatment of generalized anxiety disorder, or the management of generalized anxiety disorder. I guess for people watching, what is, and actually for me as well, because I might not actually know the true definition of it, what generalized anxiety disorder is.
So generalized anxiety disorder is defined in the Diagnostic and Statistics Manual 5 as a at least 6-month period of significant worry that occurs most of the day, most days, about several routine things, like many different things, for at least 6 months. And people tend to have disturbances with their sleep, muscle tension, feeling anxious, keyed up and on edge, that affects their social function, their ability to be with other people and maintain relationships and build relationships, their occupational things, so it may be their job or it may be hobbies and just their routine life, or causes clinically significant distress in that person, and is not better explained by some other thing that might cause you to be anxious about lots of different things. For example, someone with schizophrenia who's really worried all the time that people are following them, and that picture on the wall may mean that I'm definitely being followed, so
right. It's this kind of underlying baseline anxiety that won't dissipate almost.
That's there most of the day, most days. Worry about, so it's, you might think of it like a worry-based illness.
I see.
Yeah, so, what if I'm this, or what if I'm that, or what if I ought to be doing that? What if I don't get this in on time, or it's often characterized by a lot of what if thinking and catastrophizing and thinking and that kind of thing. That's generalized anxiety disorder.
And is it associated with other things like going through, for example, what ifs? Say someone who's a hypochondriac, can someone with hypochondria, for example, be also diagnosed with general anxiety disorder, or would that be a complication of the hypochondria instead?
So you're touching on a different condition called illness anxiety disorder, previously known as hypochondriacism. The hypochondrium, by the way, is sort of a cartilaginous tissue. That's what it actually refers to. I don't know why it's called hypochondriacism.
Okay.
Look that up. So illness anxiety disorder is different to generalized anxiety disorder in that the sort of central theme of the person's anxiety is around illness. Oh my God, what if I have something wrong with my physical self, my body?
I see.
Oh, what if I have cancer? Oh my God, I've got a pain in my neck, I've got cancer. It's there. Oh my God, I've definitely got cancer. Oh my God. And they tend to have problems with their social and occupational function and have clinically significant distress, or both, or either. And they tend to seek, they tend to go to doctors a lot and not be reassured by, investigations and scans and things. Right. So they're separate.
I see. So generalized is really broadly anything. What if this person doesn't like me, or what if this bad thing happens in my life, or what if it's the wrong decision, overthinking everything.
That's right. And look, it's important to know that. I've just lost my speakers again. It's important to know that these definitions and the separateness of them is because of the need to be able to research these. Right. In clinical practice, it's rarely so simple as to say this person has this diagnosis, and that's the least of psychiatric assessment. In psychiatry, we formulate a patient and their situation that considers the context of their subjective experience.
Right.
Beyond merely categorizing it. Yeah. But since we're talking about research, that's the definition. And you referred to worries about, what if that other person doesn't like me? Well, we're touching a bit there on social anxiety disorder or social phobia, which is, again, a separate sort of a preoccupation with the negative evaluation of others.
I see. Yeah.
So, yeah. So
lots of complexity within it.
get me into my field, Jesse, and I'll talk your head up about the complexities.
Yeah. Yeah. And so with generalized anxiety disorder, so the research was looking at psilocybin and its assistance in psychotherapy. So what was the relationship there? It was
the relationship between psilocybin and psychotherapy?
Yeah.
So it's called psilocybin assisted psychotherapy, but really in practice, the psychotherapy comes from the medicine, comes from the psilocybin sort of psychedelic encounter, that occasions a kind of mystical experience of, it's quite difficult to sort of describe, but I guess the depths of your psyche that are otherwise inaccessible in normal conscious states.
Right.
And in that state of consciousness, that altered state of consciousness, parts of your subconscious self that might reside in your body, in your emotional realm, in your memory, can be revealed to you in a way that can only be revealed to you through mystical experiences. Now, psychedelics aren't the only way to occasion those. Holotropic breathwork is one way. Vipassana and other forms of meditation can get you there. But psilocybin and other psychedelics are sort of a simpler way to bring that about, and to bring it about in a Western context where we sort of value material things as being more real, if you like. So medicine occasioning this it's just sort of culturally more congruent. Yeah. If you like.
Okay. And so how does that again, might be a difficult one to answer quickly or simply, because it sounds like quite a complex relationship, but in terms of psychotherapy, how is that? Is it allowing people to, I'm not too sure, like is it allowing them to access memories that they otherwise wouldn't access? Or
it's tricky because sometimes what they experience seem like memories but aren't memories. So the psychotherapy is kind of the context, is kind of the holding space, the safe setting within which to have this psychedelic encounter. And the psychotherapy involves a collaborative assessment with the patient about the issues that might be around the generalized anxiety in our study, preparing them for the actual psilocybin encounter, the psychedelic encounter. So so essentially sort of making them feel safe to embark on that journey.
I see.
Developing a therapeutic alliance so they feel safe to embark on it with you around them.
Yeah. And
feel supported to kind of work through some pretty deep, painful stuff sometimes in the psilocybin encounter. So there's prep that we do collaboratively. There's a therapist dyad, so two therapists and the participant, and we work together. And then there's dosing, where you have the actual psilocybin encounter. It's a very internal experience, so people wear a blindfold and have a standardized track of music playing.
Oh, I see.
And we are there to sit with them for their day and support them in various ways through sometimes extremely painful, extremely joyful experiences too. And then we integrate those experiences after the dosing session in integration.
I see.
And so those are, that's where we sort of work with the participant through what they encountered in their journey and make sense of it in relation to how we formulated the issues. So it's
right.
You can think of it that way. And what's happening, in the brain is that the psychedelic deadens or quietens the parts of the brain responsible for self in the sort of subcortical regions in the default mode network. And in that state, that kind of temporary dampening of the connections between sensory information and how we make sense of sensory information, how we make meaning from it, is temporarily arrested.
Right.
And so it gives the opportunity to make new meaning of sensory information, of sort of They may be internal things or external things, and new meanings being positive, sort of more helpful meanings for their anxiety. So the analogy that's commonly used is that if you think a certain way enough times, you develop like ski tracks in a mountain slope. The more you ski down those tracks, the deeper the tracks are.
Yeah.
And when you have a psychedelic, especially in a sort of a therapeutic context, it's like an avalanche comes and
fills the tracks in and start again.
Fills all the tracks. And there's an opportunity to find new tracks through safer routes or better routes or more healthy routes that you can begin to create a new way of being.
Wow.
Not just a new way of thinking or doing, a new way of being. So it's quite deep. And
wow, that's so interesting.
It is so interesting. And you know, like ways of affecting your being, yourself, currently, you know, through psychodynamic psychotherapy or psychoanalytic psychotherapy, you know, they can take years of intensive work.
Yeah. Well, especially if someone has been living with that for a long time. Like, I'd imagine that is possibly also something that people might live with for a long time before they realize maybe I should seek help about this, or it could be something underlying that has become baseline for them that they don't.
Absolutely. Yeah. Some people that have grown up, you know, in certain family environments where certain needs aren't met and feel anxious may not know that they feel anxious because it's normal.
Yeah.
For them. They may never have identified it as a sort of an anxiety problem. We all feel anxiety, by the way. It's a normal human state, but where it has been present always.
Yeah, you wouldn't know anything different.
Exactly. Yeah.
Yeah. That's so interesting. So you're literally remodeling their relationship with all kinds of different things, including like their sensation of fears or anxieties, like remodeling what that means to them. And
absolutely. Yep. So, you know, for a person with a generalized anxiety disorder, they might feel a kind of like tightness here, and that automatically means that sensation automatically means, I don't know, I'm about to have a panic attack.
Right.
So, and then it causes a panic attack, for instance, or it means that, oh, people around here don't like me, I'm noticing. And it's very subconscious. It may not be that explicit.
Yeah.
It may be very implicit. And so, yeah, I guess the psychedelic and therapy, you know, sort of can change the meaning that's made of that sensation to, oh, maybe I'm just noticing that this is a weird situation and people seem tense for something. And it may not be about me. It may be some other thing.
Right.
Maybe there's some dynamic between those people over there, that, you know, that the meaning made of a sensation.
Yeah.
Yeah.
Kind of changing the way the brain responds to it, almost just
the way the
mind makes meaning of it. I think.
I'm sorry. My field's fraught with all kinds of different ways of thinking about this stuff. Yeah. I'd
imagine psychiatrists could easily go back and forth on things at the same time, right? It's probably a whole bunch of points of difference between people.
And like I've been saying, you know, our field is a constant sort of dialectical tension between objective ways of understanding and subjective or intuitive ways of understanding, or objective and subjective you know, epistemologies, or like ways of determining what is real or true, and that's why it's so interesting to me, because because it's almost by definition an immaterial field. The more we learn about neurobiology, the more material it does become, or the more material knowledge we gather. But that's where the grayness exists and the complexity, and why it's endlessly interesting. And rewarding, from my point of view. So
it's just the relationship and the use of psilocybin and the way that can work. That blew my mind as soon as you said the ski tracks, and then I started to make sense of what that really meant. That's just something that even when I was trying to make sense of the research when I'd first kind of read through the title, and I was like, oh, okay. I was like, I think I'm just going to have to ask and see, because this sounds really deep but really interesting. So
yeah, it is.
It's wild. Yeah.
More than happy to talk more about anything, Jesse. Like, I love thinking about this stuff, all of it, and our field, because you know, our field is scientific. You know, in that we use the philosophy of science to determine what is. So what you know, what is it? What can be empirically proven? You know, is one way of determining what is. But we also use other ways that are more subjective, about what is true to you, the person, for you, about you, and about the world.
Yeah.
And doing that through an ethical kind of way that puts the patient's needs first, and you know, is, if you like, is psychiatry that kind of, you know, horizontal plane of a triangle with three corners. It's the science of psychiatry, the art of psychiatry, and the ethics of psychiatry. They're all just as important as each other.
Right. Yeah.
And so it's just constantly very interesting, very rewarding.
Yeah, absolutely. And well, that was something that I actually realized I didn't get a chance to ask it before, is we've talked about a few different illnesses that you might come across in the practice. Looking at, and obviously you've moved, I don't know whether or not there's a big difference between your experiences so far in rural practice versus in, say, metropolitan or city-based practice. But what would you say are kind of the more common illnesses or conditions that people are presenting with in psychiatry in Australia?
Oh, well, I mean, there's plenty of epidemiological data on this. Essentially, the most common things are anxiety disorders overall, of which generalized anxiety disorder is one, and depressive disorders like major depressive disorder is another. Yeah. And the last I looked, something like 20% of Australians will experience an episode, at least one episode of major depression or an anxiety disorder in their lifetime.
Right.
It's huge, and you know, that has, I think, implications for our culture and society, and for what is just sort of normal human existence in that cultural and societal context, that are worthy of thinking through. Why are 20% of people experiencing a depression or anxiety? What is it that's happening
what's
in our cultural, societal context? Or is it just that those people have some problem? I don't know that that's necessarily true. Yeah.
But I guess it goes back to that thing of it's also a hard thing to ever make a complete generalization about what the primary cause of something is, because again, you might have two people that say are experiencing major depressive disorder. They might have there might be a very similar, say, subpopulations or demographics or lots of other external factors, but there might still be some distinguishing difference between them. And it would throw the generalizations in the bin in a way, in that, you know, there can be differences and then you still get the same outcome, or just even people's experiences of different mental illnesses or mental health issues would vary quite dramatically.
Absolutely. And that's well established in the literature. You know, major depressive disorder has 9 criteria. And, you know, there are one big study, you know, showed that there are something like 1,029, I think it was, different sort of combinations that people experience in this one study. Oh, wow. So there's so many different permutations of just the signs and symptoms of major depression, not to mention the subjective experience of it. Very unique. Yeah. I should say also, Jesse, that I said earlier that those people, that 20% of people, these are human conditions that can affect all of us and do affect all of us.
Yeah.
And doctors disproportionately, medical students disproportionately compared to the general population. So you know, that distinction between self and other, care for others, care for self, it's really overt in our field. And you know, self-care is a big thing in psychiatry, and I think it's just important from a ethical standpoint to just be cognizant of just our own vulnerabilities and our own sort of way of seeing others as fellow humans, fellow sufferers, if you like, that are worthy of love and care, just as we are.
Yeah.
Yeah.
Yeah, I guess that's it's something that I looked at a lot in my undergraduate degree, which is a long time ago now. And I did a subject that was called the History and Philosophy of Medicine.
Awesome.
And it was brilliant. I loved it. It was the one that was very outside of the field that I was studying in, but it was still that I did a science degree, but it was different because it was a philosophy subject. And that I realized that subject had such an impact on me in the way that I think about the relationship between patient and doctor, because a lot of it was very much quite critical actually of the historical culture of medicine and the barrier that's put up, but again, from its origins, the barrier that was put up between doctors and patients, and things like analyzing and dissecting the language that's used. I remember I did my final assignment, I did a whole essay on dissecting the statement of what appears to be the problem, or what seems to be the problem, as being the classic opening line from a doctor, and why that assumes that the patient is wrong.
And diseased, not us.
Yeah, exactly. That too. It's like it creates that barrier. Yeah, and it's the us-them concept that can become.
And those are some of the implicit self-interest things that you need to be mindful of in all medicine, and psychiatry especially. Of, do I need to see myself as the healthy one, and I'm the one that's okay? And am I, in treating this patient, reinforcing that need by saying that they're unwell? Yeah. Am I actually saying that I'm not unwell, when actually, oh gosh, maybe I need to really sort out the way I've been feeling about these things? I wonder if you've read Foucault.
No, I haven't.
He had a lot of criticisms about the practice of medicine as a way of sort of ostracizing deviant components of society through calling it disease or illness.
Right.
Yeah, they're different from us, so they are ill.
Right.
Is one of the criticisms, a sort of alienating role of medicine, and that literally happened in the asylum era, left unchecked. People who were just different, or people hadn't bothered to kind of consider what might have been underlying certain behaviors, and just ostracized, put in asylums and locked away. There's all kinds of stories that we don't need to go into.
I guess that's also like a much more extreme example or demonstration of it, but it goes back to that thing of, you said before, psychiatry is not ultimately about the categorization or even really focusing on any categorization. It's about formulating the patient's environment. Because even though very, very glad that we've moved well and truly beyond asylum eras, but that is ultimately one of the more negative outcomes of categorization and ostracization as well.
Exactly. Yeah, absolutely, Jesse. Absolutely. This is a topic that's very important to me, and I'm just conscious of your viewership, and not getting into the esoteric intellectual stuff too much. It's my tendency, because I find it interesting. I don't know.
But to be honest, I'm sure people would enjoy it.
Yeah. Okay.
Yeah.
Well, I guess psychiatry has been seen as, by some, as an agent, a social agent, an agent for maintaining the status quo, because what is seen as illness is, has historically been determined by the psychiatrist, and so what is seen as real or true has been determined by the psychiatrist, and that may probably isn't right. A better way to look on illness, I think, is to consider, to some extent, to what degree this causes suffering and the clinically significant distress in the person, to what extent it causes functional problems to the person, in terms of social and occupational function. And to what extent this represents a deviation of the person's normal way of being, usual way of being. For example, with episodic illnesses like psychotic illnesses, this is not how this person is according to how they normally are, based on the information I have from people that love them and care about them. Not that they're different from us.
Yeah, it's not a standardized baseline, but their own. Yeah.
Yes.
Yeah.
Own subjective way, not usual way of being. They can get a lot more complicated when their usual way of being has also caused a lot of pain and suffering, for example, in personality disorders and developmental trauma disorders, and so on, where new ways of being may cause less suffering and dysfunction.
Mm-hmm.
But also, what is seen as functional also requires its own examination, because what's functional for that person may be not how we see function. It may be that they can enjoy meaningful hobbies, within their limitations, or that they can live a simpler life. They don't need to be participating in the economy necessarily. Which is a value-laden notion of what function is. Values that are heavily sort of governed by our socioeconomic sort of system, our capitalist system.
Yeah. That's really interesting. Yeah, I never thought about that as well. Like even, defining what is normal. I mean, normal itself is so subjective.
Yeah, that's very normal.
Yeah.
All I can tell you. What is normal for you?
Yeah.
What is normal? What is normal for you? Not what is normal.
Yeah. But I guess that's also that thing that you were just saying, that like, what if then there is no baseline? So if you've got what is the baseline may actually not be helpful. Making sure that you're not intervening too much with your own, say, assumptions or definitions of what is normal or what is healthy or what is functioning in terms of helping that individual as well, because it goes right back to having to really fully understand them and to understand what works for them. But have you ever found that like have you ever had patients where it's been hard to decipher what is best for them in terms of disconnecting your own potential like individual preconceptions? Or I'd imagine you probably don't go into a consultation with preconceptions for an individual, but have you ever found that you've had to question like, this is actually quite a hard one to gauge in terms of what is best for them or what happens next?
Well, I'll start by encouraging your viewers to have a look at principles of recovery-oriented practice, because determining what's best for the patient is a different approach altogether. That sort of, I think that would be more in the intensive care setting where you can't actually access the patient's values and preferences.
Right.
And it's life or death. I mean, that's rarely in psychiatry, you have to do that, but I would consider that the way of approaching this is less about what I think is what's best for the patient and more about what we, including the patient, the family, and the team, think what is best for the patient and for the whole system that they exist in. And it's a balance between all of those things. And how you balance them depends on your sort of ethical framework, I guess, of weighing those good and bad things and your duties and all sorts of things. Difficult one to answer, but I just wanted to kind of pick up on the language there about determining good paths of action with our patients.
Yeah.
Or with, Yeah,
and I guess it's also that you just said, like, working with the entire team, having all of those inputs, it probably dilutes any conflict almost, or challenges in that you've got more data, more information, more of a bigger picture understanding of what their life is, what is normal for them more.
It can. It also might not, because there's also social cohesion pressures within teams. There may be a sort of a tendency for conformity because there's less interpersonal conflict then. And so if this is called groupthink, and so if, as the leader of the team, as the psychiatrist, you're noticing consensus being reached far too quickly, you may have groupthink on your hands, and that may not be best for the patient. It may be best for the team and their social cohesion. So there's this constant
tension. Advocate for the patient and make sure that there's enough discussion. Yeah.
And you're not immune to this as well as a member of the team, by the way. It requires a lot of sort of insight and self-reflection and constant monitoring of your own reaction to things. That is, it's demanding. It requires a lot. Yeah. And at the same time, have some influence within the team to perform its functions proficiently and ethically. Yeah.
Cool. All right. Well, I didn't want to keep, I know we've gone a little bit past an hour, and I didn't want to take up too much of your Friday because I know that you're very busy, but I wanted to ask just at the end, we normally finish the episodes with just a little bit of advice for people that are watching. I take it as a little bit of selfish advice to myself at the same time as someone who's pursuing the career. But for someone who's watching and is either in medical school right now or interested in pursuing psychiatry, even if they're not as interested in psychiatry, when a medical student is on their psychiatry rotation, what would be your biggest piece of advice for them to really kind of take advantage of that experience?
I would say foster your curiosity. Be curious, be open, ask questions. And I think if you're guided by that, and if you're guided by genuine care and compassion, you really can't go wrong. And I think that curiosity in psychiatry especially ought to extend to yourself. Why did I have that reaction to that situation? Why do I feel like I really don't like that patient? Why do I feel like I really don't like that consultant? Or I do like that consultant? Just examine with curiosity the experiences that you have when you're in psychiatry. And within psychiatry, there is a culture of examining those things together. So, if you feel like you have the safety in the relationship with your registrar or consultant, then consider even saying, I noticed that I was feeling like this. Ask to talk about it.
Yeah.
I would say.
Yeah, that's great advice.
And aside from that, check out the college website, because I didn't get through all of the training program stuff. It's all up there about the competency-based stuff and the summative sort of centrally administered assessments and the formal education programs that you can get started on and will do.
Perfect. I'll make sure, actually I can link it in the description below, and I'll make sure everyone can jump onto that. That's the Royal Australian College, right? Of Psychiatrists. Yeah.
Yeah, and there's some useful information there about the training program and the different stages and all the rest of it. It's all there. Yeah, and talk to people at your med school about it if you're interested, and or at your workplace about it. The hospital coordinators of training are a really good resource.
Yeah,
because they know.
Absolutely. Well, you'd know. So.
And the registrars, of course, who are in it. Yeah.
Yeah. Cool. All right. Well, thank you again so much for your time today. It's been I've gotten so much out of this conversation. It's just been very, very eye-opening. Lots of stuff, just genuinely interesting things like the research, but also just understanding a lot more about psychiatry. Because for me personally, it's a field that truthfully, I don't think I've really thought about much more so because I haven't really known much about it. And I'm sure everyone watching has gotten a lot out of such an in-depth kind of look at what the practice really looks like. So thank you so much.
It was my great pleasure, Jesse. I'm more than happy to talk again if you'd like to. I enjoyed it very much too, especially with your interest in pediatrics. You can certainly do some similar work in child and adolescent psychiatry that you might do, just with a different approach. So please do stay in touch. And if you'd like to talk more, I'd certainly welcome another conversation. It was my great pleasure.
I hope you enjoyed this episode of the Dissecting Medicine podcast. Please leave me a comment with your thoughts and share this episode with others that might benefit. Otherwise, thanks for listening, and I'll see you next time.